All right, everybody. First off, everybody forget that lunch is a thing. It's always hard to go as the last presentation right before, but I'll speak as fast as humanly possible. So what I'll be talking, my name's John Santoro. I'm just up the road at Children's Hospital Los Angeles and USC. And what I'm going to talk about today is regression or Down syndrome regression disorder. This is an emerging condition. We've known about it for a long time, so I'm going to go a little bit about what it is, talk about where we're going with some of the diagnostic biomarkers, and then talk about our exciting clinical trial at the very end of it as well. So when I'm saying regression, well, that can mean a lot of different things. And I think that really what we have to focus on here is that regression is just a word, but we're referring to it as a loss of previously acquired developmental skills. And this can look like many different things. This can be in toileting, activities of daily living, making yourself a sandwich, taking the bus, to a place, the ability to communicate with other individuals, motor function, social interaction. And a key here is that regression can be caused by many different things. Question I get a lot is regression common? And we think that it's relatively rare. And I keep updating this slide to say less and less, but we think that this is only occurring in a small, probably single-digit minority of all individuals with Down syndrome, including individuals with Mosaic Down syndrome. And I think when we talk about neurologic disease in individuals with Down syndrome across the lifespan, it's really important to think about, well, when can regression potentially occur? And so you can have an epileptic regression. So this is basically having a seizure disorder that would cause you to lose some of your developmental milestones. This is usually infantile spasms in the first few years or first few months of life, really. That can also be called West syndrome. There's autistic regression. So we know that both from individuals with and without Down syndrome, that developing autism often is first diagnosed in the setting of a loss of other developmental milestones. We'll talk about what Down syndrome regression disorder is. Alzheimer's disease can also be considered a regressive disorder because you're having a high functioning status and that slowly is deteriorating over time. And lastly, there's systemic manifestations. So these can be things like having a thyroid dysfunction can actually make you seem or appear to have a regression of your other skills. And we would call this a mimic of regression because there's another medical cause for this. So we'll be focusing on this middle session. I mean, eventually we'll have a neurologic Down syndrome seminar at some point as well, but today we'll just highlight the middle area. But I think that when we're looking at these neurologic disorders in individuals with Down syndrome, there is this common theme. And I think that Dr. Sullivan was kind of hitting at this with some of these immune biomarkers. When we look at infantile spasms, this is a specific condition, an epilepsy, that we don't actually treat with anticonvulsants. We treat with steroids, and the patients get better. With neurovascular disease, we're finding that more and more individuals with Down syndrome actually have both personal autoimmunity and familial autoimmunity when you develop this, cerebrovascular disease. I'll show you some slides on Down syndrome regression disorder. Not only are we finding biomarkers of inflammation, but we're also finding that individuals are responsive to immune treatments for a previously considered psychiatric disease. And Alzheimer's disease is very complicated. You're going to hear from Dr. Mobley a little bit later in this conference, but there are some data to support that there's an immune piece of the puzzle with that condition as well. So what are the symptoms? The key feature here is look at these, blocks in blue, and then really apply them to be a sudden or dramatic onset. So these are not individuals who have always had poor sleep or always had a little bit of OCD. These are individuals who are previously high functioning and over the period of days or weeks deteriorate. An old term that we were using for this condition was Down syndrome disintegrative disorder. And we don't use that term anymore. We're calling it regression. But I've had many families say that they walked in the next day and it was like a ghost had replaced their child. There's somebody else there. The functioning deteriorates very quickly. These can be preceded by stressors. So this can be a family member moving away to college. This could be an individual whose parents are getting divorced, bullying at school, or infection in some situations. And really, for what we're talking about today, I'm talking about individuals who are really between 10 and 30 years old. Before that, in the single-digit age group, we're always thinking about, is this autism spectrum disorder or not? And in the latter age group, we're thinking about, is this Alzheimer's disease or not? So we're really kind of honed into this specific range. When we're talking about these symptoms, insomnia, difficulties falling asleep, some of our patients will just stop sleeping. They'll get an hour of sleep a night. Sometimes they'll sit up in their bed and laugh to themselves. And that's how we figure out that something is very, very wrong. Encephalopathy, or being off in your own world. These are individuals who are normally very happy, engaged, talkative. Now they're sitting out, staring out the window, and will continue to do that throughout the day unless you actually break them out of it. New autistic features. So these are individuals who don't have a diagnosis of autism and now are suddenly not making eye contact, not showing any empathy, and they're not really engaging with other people around you. A freezing or a bradykinesia. So it almost looks like in some of these patients that they have Parkinson's disease all of a sudden. They'll slowly shuffle around, or you really have to move them from place to place in the home. And that links in very closely with catatonia, which is a muscle stiffness. And I'll show you some slides and examples of that in a moment. Obsessive compulsive disorders, this is not touching the door, 15 times before you leave a room. This is an obsessive compulsive thought process. So it's like these individuals are stuck in this loop of thinking and they can't get out of it. Often it'll be focused on something that they know a lot about, a particular TV show or a movie that they really enjoy, and they just will not stop talking about it. And even when you interrupt them, it's just for a few seconds that you can get in, and then it's right back to talking about it again. And finally, we see psychosis, hallucinations, delusions. These are going to be the very obvious things where you say, wow, something is not right. These are individuals who are responding to internal stimuli. They hear or see things that are not necessarily there. And lastly, we'll often see that individuals lose the ability to speak. They'll often start decreasing the total number of things they say, then they start to whisper, and many of them end up becoming quite mute. This is not a new condition. This was first reported in 1946 by Rollin, and this was in individuals who were hospitalized for psychiatric disturbances. And this is an example of this catatonia, this stooped posture. These are individuals who are high functioning out in the community even in the 1940s, and then were put away in a mental asylum after that. There is a checklist for these, and this is kind of a plug for the NDSS. They have created a checklist with us, so please check out their website. But ultimately, this is not something that you're going to be like, oh my God, my son or daughter has Down syndrome regression disorder. You really have to have a discussion with your doctor about many of the symptoms that we're talking about to help determine, is this consistent or is this inconsistent with the condition? So let me show you some slides of what these symptoms can look like. This is an individual who lost the ability to speak but could still write, and she wrote, brain hurt, brain fog, call 911. So obviously an individual who's in quite a bit of distress and can't necessarily communicate that out. This is an example of catatonia. So individuals, if you put them in a particular arrangement, they just stay in that position unabated. So this individual will do this for 3 to 4 minutes until you actually physically put his arm and leg down. This is another individual who has lost about 40 pounds because he takes so long to eat that he is losing weight. So it takes him about 3 to 4 hours to eat a meal. You can see he just gets stuck in these positions. And in the latter part of this video, we'll try to turn him as well, which is essentially impossible. This is a young man who was previously able to speak, mainstream classes, the whole nine. We also see that there's a lot of dermatologic changes. So you saw in Dr. Sullivan's presentation that individuals with Down syndrome also get these skin changes. These are new skin changes that develop at the time of these other symptoms that we're speaking about. You can see these dark patches, which we think are actually something called ichthyosis, which is another JAK-STAT-mediated type of skin change. When you use a Woods lamp, you can actually see underneath the skin at the hypopigmentation, the destruction of some of these cells along the way. That's on the far left over here. And then in addition, we have patients who develop this intense dandruff out of nowhere. And initially, I can't say I was looking at this and saying, well, this is a dermatologic change. But when you see it in enough patients over and over again, we start to make these connections that there's probably skin plus neurologic manifestations in this condition. So what are the differentiating factors? How do we know this is an autism? How do we know this is an Alzheimer's disease? The first is we look at the age, right? Again, we're in this age cluster between 10 and 30-ish, although we are starting to hear that there are cases of regression on both age extreme. The precipitation, so the stress, is there an infectious trigger? This is up to 60% of individuals. Something tips this process off. The speed of the onset, I think if you walk home with anything here, speed matters. So these patients go down very, very quickly. This is not a chronic, multiple years type of process. And then the symptoms were all the ones that we were just noting. So really with, the work that we're putting together on, from Dr. Sullivan and Dr. Espinosa's group on the immune regulatory issues that we see in individuals with Down syndrome, then we pair it up with this stressor, whether that's psychological or environmental. So you have a predisposition to inflammation, something is triggering you off, you get this cascade that gets activated, and we think in this condition, this may be explaining some of these neuropsychiatric features that we're talking about today. So what do we do about it? So how do we rule it in? How do we rule it out? The original approach was very conservative. It was kind of this tiered approach where we would say, all right, we'll start with these easy to get tests and we'll keep going through it. And that was taking a lot of time. And it was, often a year plus in some instances of testing to rule out other conditions. Our approach now is a little bit more rapid. So what we do is we identify first that this is consistent with Down syndrome regression disorder, that the speed of the symptoms is different, or the symptom cluster is different from other conditions, and then we try to get everything in rapid sequence. So what are we getting? A lot of different stuff. Right now, the diagnosis of Down syndrome regression disorder is one of exclusion, meaning that we have to rule out all the other potential possibilities before we arrive at this diagnosis. This includes getting blood work. We're ruling out metabolic, GI, nutritional, infectious possibilities. An MRI of the brain is basically a picture of the structures of the brain. Here we've been able to determine if there's inflammatory or even stroke in some situations that mimics the symptoms of regression. EEG is helpful to look at seizure activity. We've found in a soon-to-be published study that EEG identified 3 individuals with this condition who had very rare frontal lobe epilepsies that ended up causing a mimic of these symptoms. And finally, a lumbar puncture, a spinal tap. This is to actually look at the cells that are in the brain. You have a barrier that protects your brain from your body. It's why every time you get sick with a virus, you don't get meningitis. It's this barrier keeps everything out. But that's also why I can't test for inflammation in the brain from the blood. We actually have to use a needle to go past that barrier and sample the fluid. So when we first started looking at this, we started to say, okay, well, how frequent are these things abnormal? And we found that EEG is abnormal in about 26% of cases. The neuroimaging abnormalities are in about 20% of patients, and CSF or cerebrospinal fluid is abnormal in roughly 20% of cases as well. These white spots that you can see on the back of the MRI over here, let me see if I can do this pointy thing now. Top button. There we go. I have bad aim apparently. These white spots that we see on the back of the MRI, these are lesions that we would normally see in somebody who has multiple sclerosis, but they're too small for individuals with multiple sclerosis, but they're also too large to be something incidental or just, a birthmark on the brain. We also see this other signal, this darkness in an area of the brain called the basal ganglia. The basal ganglia is a part of the brain that controls movement, it controls speech, and it connects with the frontal lobes to basically have behavior. And this is one of the seats potentially for autism as well. And so it's interesting that this area is impacted because it correlates out with many of the symptoms that we're actually seeing. Oops. This is just a fancier picture. And when we've now been able to expand our cohort, so in 233 individuals that we have MRIs on, this particular signal, there's a darkness in the basal ganglia that keeps coming up more and more. And when we actually look at who is responding to which different type of therapy, which I'll get to in a moment, people with this type of MRI are 9 times more likely to respond to immunotherapy. What's very interesting is if we, pretend for a moment that all of the inflammation, all of the autoimmunity in individuals with Down syndrome is interferon related, what we do is we want to compare it to another disease that is interferon related, and that's Aicardi-Goutieres. You do not need to remember that. That's just for us weird neurologists to throw off. That's a 10 out of 10 interferonopathy. They have the exact same MRI as individuals with Down syndrome and regression. So we're talking about a lot about the immune system, and you've already heard a lot about it. But I think that when I try to think about this on the bigger picture, because I am definitely not a basic scientist, all of these fancy graphs and things actually give me quite a bit of anxiety. I look at it as this. So in individuals with Down syndrome, right, and in individuals with Mosaic Down syndrome, you have extra receptor or interferon receptor expression. And receptors are like your satellite dishes, right? So an individual with Down syndrome is really just looking at the body and focusing and trying to detect any possible noise. And so when it finds anything, maybe an infection, maybe a stressor, it starts to trigger these immune-mediated cascades. And that's the way I kind of want to conceptualize this, or at least this is the way that I do. And we already know a lot about this. We know that individuals with Down syndrome have increased autoimmune diseases. And from there, we want to use that to justify treatments. So at this point, we don't have one singular treatment for this condition. I think it really matters what the most likely etiology is. And even though I'm showing you a lot of slides about the immune system, and I'm going to show you even more slides about immunotherapy, not all patients respond to immunotherapy. And this is a very important piece to consider. When we look at what is available, there's a lot of different medicines that have been tried. Many of these are existing from the days before where we thought this condition was psychiatric. So we've tried antidepressants, we've tried antipsychotics, benzodiazepines, which are used to treat the catatonia. Electroconvulsive therapy is another catatonia treatment. And I'm going to focus on the immunotherapy here. This is because I'm a neuroimmunologist, so I have to talk about this sort of stuff. But when we first started treating patients, we wanted to use a protective immunotherapy, something that wasn't going to suppress the immune system and had a variety of different targets. So we found that in individuals with these MRI or CSF or EEG abnormalities, they were 4 times more likely, or that's where the odds ratio of 4, more likely to respond to immune treatments than any of those other treatments that I was talking about. On the top here, and again, because I'm not a neuroimmunologist, I like to ignore the non-neuroimmunology things. If we look over here, the antidepressants, antipsychotic, and benzodiazepines are 5 times more likely to respond or to have an effect in individuals without these abnormalities. Again, there's this difference in terms of the phenotype based on the actual studies that come back. At first, we were really rigid, though. I said you had to have an MRI or CSF that was abnormal, otherwise I wasn't going to treat you because I don't want to do any harm. That's my first duty as a doctor. And then we saw that there was a 90% response rate. And we said, all right, well, we have to offer this to other patients without these abnormalities. And we found that IVIG, or intravenous immunoglobulin, which is, again, an immune-boosting medicine that hits many different targets, actually worked for individuals without these abnormalities as well. But an important thing down here is when we start to see these other immunotherapies, they're not responding to any of those. So there's something very nuanced about this particular patient population, and one that we need to be a little bit more conscientious and cautious of when we do advanced immunotherapy. We have a clinical trial. I'm going to show you some slides on that, but turns out the immunotherapy is not just helping the patients respond to those symptoms I showed you earlier, it makes their skin better too. So this is our first trial patient who has these dark plaques all over his body that he developed at the time that he developed his neuropsychiatric symptoms. And this is just 21 days after starting immunotherapy. So really gone. Another question we had was, well, if we're going to start patients on these immune treatments, how long do they have to be on them, right? If we are thinking about this as a chronic immune condition, a la multiple sclerosis or lupus, these patients are on therapies for the rest of their lives. So we got crazy. We said, let's try to take patients off of these immune treatments at 1 year and see what happens. Well, lo and behold, we found that about 50% of patients keep the gains that they made, and the other 50% actually relapse. They go almost back to where they were before. And I think that this is a really important piece. Is when we look at this, this may be a situation with Down syndrome regression disorder where we can actually get the train back on the tracks in some patients if we're proactive about it and we actually start these treatments very early. There are very likely to be some patients who require long-term therapy. And this is where we really need to go and find more data to determine who is going to need that and who is not going to need that. So there are individuals with Mosaic Down syndrome who are developing DSRD. And it's a little complicated. Is normally we think of individuals with Mosaic Down syndrome as having more mild or more moderate phenotypes. And in regression, it seems to be the reverse. So all of these patients had very severe and dramatic presentations. They almost never have any of these neurodiagnostic studies coming back as abnormal, as I showed you earlier. And 60% don't respond to immunotherapy. So it's like the reverse of what we would expect. These patients should be even more easy to treat. The only key piece here that I want to bring up is the duration of the symptom onset to the time of diagnosis was 2.5 times longer in this group. So often these patients were diagnosed with, oh, well, this is just depression, this is anxiety, this is something else. And it was put under the rug, whereas many of the individuals with more severe presentations who had Down syndrome without, mosaicism actually got access to treatment quite a bit earlier. And I think many of you in this audience are probably familiar with this, where you're an individual with Mosaic Down syndrome is functional enough where many of the common explanation for things are utilized, but often may be involved in more in this group of individuals with Down syndrome who are generally going to be worked up a little bit faster for all of these things that we know about individuals with trisomy of chromosome 21. So it's more refractory, it's more severe, and I don't have an explanation for it, but it is something that we're actively researching, especially from a proteomic standpoint, where we really want to find if there's something inherently different in this population. So what are the next stages? I'm putting up a picture of the first black hole because that's what it feels like we're going into sometimes in research. But we have our first clinical trial. This is an awesome collaboration that we have with the University of Colorado and the Children's Hospital there. We enrolled our first patient on June 20th, and this is an open label phase 2 study where we're comparing lorazepam, which is a treatment for catatonia and not immune therapy, IVIG, which is much of the data that I've showed you already, and tofacitinib, the JAK inhibitor that Dr. Sullivan was speaking about earlier. There is no placebo group in this study. So we're looking again at safety first, efficacy second, but in individuals who haven't received any of these therapies in the past, they have the ability to run in, meaning that there's 12 weeks where they don't have to be on any treatments before the study starts. And this is our study team. There's a really handsome guy over all the way on the left there. But again, this is a collaboration that we have with the University of Colorado. And just so everybody's aware, I think you guys have seen this slide. Phase 2 is really looking at the safety in the specific population. Obviously, we're very concerned with efficacy, and we have some very exciting data for that, but we need to prove it at this point. These are just the 3 different medicines. Lorazepam, again, is also known as Ativan. This is a medicine that just treats catatonia. So we want to make sure that the immune treatments are actually doing more than the catatonia treatment, and that's why we have that as a direct comparator as well. So why are we doing this? I mean, one, we want to find medicines. One, we want to find cures for this condition. And we also want to figure out who would benefit the most, right? We've shown you some pretty interesting data about which patients are responding to therapy and which patients are not. But we need these biomarkers so that way an individual comes in with regression, we can get a profile very quick and say, you know what, this is going to be the preferred therapy for you. And I think that really the message from individuals with Mosaic Down syndrome is they have a different profile. We may need to go back to the drawing board and think more about what therapies may be more or less effective in this population as well. I'm putting up some emails. If you have a loved one or know somebody who might have this, please do email us. I included the CHLA and the Colorado emails up there. They are remarkably similar, so just be careful when you're emailing. If you email us to one and you want to be reaching Colorado, for instance, we can send you back and forth too. That's no problem. All right, I hope my video will work. There we go. So this is an individual from Oregon who comes to see us. Mom put together a video of her before and after. Oh, come on, video. Get impatient and try again. How about this? I can show you it afterwards if anyone's interested, but essentially, high-functioning individual writes, during her regression, she can't speak, she rocks back and forth, crying intermittently and not sleeping, and she was one of our hyper responders. So after IVIG, within, I think, about 5 or 6 weeks, she got back to the point where she was essentially 90% back to her functional baseline again, which was a real encouraging story. I'm sorry I can't show the video. This is like a huge bummer for me, so we'll try it again. Oh, wait. Yes. Let's see if my description matched.
Go away. I am now going to go to bed.
Yeah. Are you ready for the next movie? Huh? Are you? Friday. Happy Friday.
This is fired. I mean, the way you can come and say the way calm down.
Yes.
I mean, still wet.
Sweaty?
Still wet here.
Sweaty. Go take a shower.
Did you get that sour?
Yeah.
Can't hear you there.
Can't hear you say it? Okay, Kristen, can you go take a shower?
As you can see, a hot summer in Oregon that year, but I think it just goes to show, I mean, this is an individual who had these symptoms for 2 years, had basically done nothing but rock on the floor. And we're seeing these really dramatic responses. And I think the hope here is that we can actually identify these individuals earlier now, get the testing we need done earlier, and hopefully make that 50-50 percentage more of an 80-20 percentage over time. So with that, I'll leave our email up there again. I'm happy to answer any questions afterwards. I don't want to prevent you from getting Chipotle because I know if you step between somebody and Chipotle, bad things happen. But thank you very much.